Hello everyone, today I'll be presenting my week 2 case presentation. This case is from a scenario from last week at my family medicine site. So the patient is a 43-year-old white male who presented to the clinic with the chief complaint of urinary difficulties. The patient conveyed that he had difficulty starting his stream of urine as well as completely emptying his bladder. This patient reported that his symptoms occurred on at least 3 days out of the week and occurred at varying times during the morning, afternoon, evening. There wasn't a specific time when the symptoms typically occurred. He denied using any medications or utilizing any interventions that would help improve his urinary symptoms. The patient also denied any dysuria, foul-smelling urine. He also denied hematuria. He also denied the risk factor of STIs and also any history of STIs. So the medical history for this patient is type 2 diabetes, hyperlipidemia, and anxiety. The patient's medication regimen includes metformin, simvastatin, and lorazepam. For the patient's most recent labs, his hemoglobin A1C was 5.2, and his most recent total cholesterol was 170. The plan for this patient was to initially order a UA to rule out UTI, order a PSA to assess for the presence of BPH, as well as a post-void residual. There was no actual assessment of the patient's prostate during the visit, but often this is performed, an assessment of prostate, and usually the result that's often yielded on examination is an enlarged, firm, and non-tender prostate. So the differentials for this patient included BPH, UTI, and prostatitis. BPH was ruled in due to the patient's symptoms of urinary retention. UTI was ruled out due to the patient's denial of any dysuria, as well as no reports of any back pain, and also the normal UA that didn't reveal any suspicion of leukocytes or proteinuria. Prostatitis was also ruled out due to the patient's medical history, which was negative for UTIs, and due to the patient's denial of any dysuria. The medication that was prescribed by my preceptor for this patient was Flomax 0.4 milligrams daily. The Flomax is under the class of the alpha-1 reductase inhibitors. And due to this medication class is associated with a variety of side effects. So one of the patient teaching points for this patient was to discuss the potential side effects, which include retrograde ejaculation, erectile dysfunction, nasal congestion, hypotension, dizziness, and tachycardia. The follow-up for this patient was to return to the clinic in 2 to 3 weeks to reassess his symptoms. For my references, which I used for my differentials as well as a plan, I used Cash and Glass, the 2017 Family Practice Guidelines, 4th edition, page 341, Medscape Benign Prostatic Hyperplasia Workup. This is published in 2019, and article Jaraka et al. Titled Review and Update of Benign Prostatic Hyperplasia in General Practice, from published in the Australian Journal of General Practice in 2018. Thank you. Have a good night.